Carpal tunnel syndrome is an entrapment neuropathy caused by compression of the median nerve in the carpal tunnel at the wrist. The carpal tunnel is an anatomical compartment bounded on three sides by carpal bones, which form an arch, and on the palmar side by the transverse carpal ligament. It contains the median nerve and the flexor tendons. Reduction in the dimensions of the carpal tunnel or increase in the volume of its contents produce an intermittent or sustained high pressure in the tunnel, which causes ischemia of the median nerve and impairs nerve conduction, leading to pain and paresthesia in the distribution of the median nerve. The majority of cases of carpal tunnel syndrome are idiopathic, with no known underlying cause. Potential risk factors for its development include activities with high hand wrist repetition rate, repetitive wrist flexion or hand elevation, such as gardening, assembly line work, such as some packing tasks, and occupations requiring forceful or repetitive hand grip exertion. Use of vibrating hand tools. Note that there is a lack of consistent evidence in the literature regarding the link between carpal tunnel syndrome and computer work. Obesity, pregnancy, osteoarthritis of the metacarpophalangeal joint of the thumb due to compression of the median nerve by osteophytes. Inflammatory joint disease, such as rheumatoid arthritis, due to synovitis in the carpal tunnel, ganglion cysts, tumor, scar tissue. Hypothyroidism, diabetes mellitus, conditions encroaching on the space within the carpal tunnel, e.g., aneurysm, neurofibroma, hemangioma, lipoma, ganglion, xanthoma, and Gaudy-Tophi. Carpal tunnel syndrome can impact daily functioning and sleep due to symptoms of pain, paresthesia, muscle weakness, and impaired dexterity. Sustained high pressure on the median nerve can lead to constant, severe symptoms with persistent sensory and motor deficits. Prognosis. Symptoms of carpal tunnel syndrome may resolve spontaneously in some people. One observational study found that symptoms of carpal tunnel syndrome completely resolved without TR. Treatment in 34% of people within 6 months of diagnosis. Spontaneous recovery was less likely to occur as age increased. A prospective follow-up study of untreated people with idiopathic carpal tunnel syndrome found that good prognostic indicators included short duration of symptoms, young age, and carpal tunnel syndrome due to PR. Poor prognostic indicators included bilateral symptoms and a positive Phelan's test. A prospective study of 132 untreated people followed up for an average of 2 years found on patient-completed symptom questionnaire, in 23% of cases the severity of symptoms worsened. In 28% symptoms remained stable, and in 47% symptoms resolved. Following nerve conduction studies, in 7% there was electrophysiological deterioration, in 67% disease was stable, and in 25% nerve compression had objectively improved. If a diagnosis of carpal tunnel syndrome is suspected, ask about the onset, duration, site, severity, and impact of symptoms. Typical symptoms include intermittent paresthesia, numbness or altered sensation, and burning or pain in the distribution of the median nerve, the thumb, index finger, middle finger, and radial half of the ring finger. Symptoms may affect one or both hands. The symptoms of carpal tunnel syndrome have been estimated to be bilateral in up to 73% of cases, although they may not present at the same time. Some people may present atypically, for example with sensory changes in all fingers, or with pain in the hand radiating up into the wrist, forearm, or shoulder. Symptoms are often worse at night and can wake people from sleep. The affected hand may be hung out of the bed at odd angles to try to revive it. Relieving factors include changing hand posture or shaking the wrist, the flick sign. There may be loss of grip strength, hand weakness, and reduced manual dexterity, for example when doing up buttons, holding objects, and opening jars. Severe disease may cause persistent symptoms and neurological deficit, constant sensory deficit, or thenar muscle wasting and weakness. Additional conditions or risk factors for developing carpal tunnel syndrome. Any previous episodes and treatments tried. Any history of trauma or red flags which may suggest an alternative diagnosis. Examination. Examine the entire upper limb, including neck, shoulder, elbow, and wrist to exclude an alternative diagnosis, particularly if there is an atypical presentation. Assess for typical signs which are more likely with prolonged or severe symptoms, such as trophic ulceration at the tips of the digits, rare, indicating loss of protective sensation. Wasting of the thenar eminence muscles, sensory loss in the distribution of the median nerve. Weakness of thumb abduction and opposition. Reduced hand grip and pinch grip strength, reduced hand coordination. Perform hand provocation maneuvers, which may support a diagnosis of carpal tunnel syndrome. Phelan's test. Positive if flexing the wrist for 60 seconds causes pain and paresthesia in the median nerve distribution. Tinel's test. Positive if tapping lightly over the median nerve at the volar surface of the wrist produces paresthesia or pain in the median nerve distribution. Durkin's test. Carpal tunnel compression test. Positive if direct pressure over the proximal edge of the transverse carpal ligament, proximal wrist crease, with the thumbs produces or worsens paresthesia in the median nerve. Distribution. Be aware that referral for nerve conduction studies is not usually needed if there are typical symptoms of carpal tunnel syndrome. Consider arranging referral, depending on local referral pathways, if the diagnosis is uncertain. Referral for surgical management is being considered. Differential diagnosis. Alternative conditions which may present similarly to carpal tunnel syndrome include cubital tunnel syndrome. Ulnar nerve compression at the elbow causes paresthesia of the little and ulnar half of the ring finger. Weakness of the small muscles of the hand but not the thumb, and there may be rapid weakening of hand grip. Cervical nerve root entrapment radiculopathy, especially at C6-7 level, may present with neck pain, with radiation of pain and numbness to the arm and hand and a dermatomal distribution to the thumb and index finger. De Quervain's tenosynovitis. This presents with pain over the distal radial styloid due to irritation of thumb tendons when they run through the fibrous sheath. Osteoarthritis. Osteoarthritis of the metacarpophalangeal joint of the thumb may present with pain on activities requiring thumb pinch with twisting action, such as opening jars or turning keys. There may be a positive grind test. Applying pressure towards the wrist joint and twisting reproduces pain. Inflammatory arthritis. There may be prolonged mooring stiffness and signs of joint swelling and synovitis on examination. Trigger thumb. There may be pain and a palpable nodule over the palm or aspect of the metacarpophalangeal joint, with clicking on thumb flexion. Vibration white finger or hand-arm vibration syndrome. There may be a history of use of vibratory hand tools and Raynaud's phenomenon. Raynaud's syndrome. Thoracic outlet syndrome. Neurovascular compression in the thoracic outlet may cause shoulder and neck pain with associated finger numbness. Peripheral neuropathy. This may be due to conditions such as diabetes mellitus, hypothyroidism, and B12 deficiency, and there may be bilateral lower limb involvement. Motor neuron disease or multiple sclerosis. Fracture. This may be suggested if there is a history of trauma. Peripheral nerve or other tumor. There may be rapidly progressive symptoms, with severe pain and swelling. Pronator syndrome. This is compression of the median nerve where it passes between the two heads of the pronator tears, causing pain in the wrist and forearm and weakness of the thenar muscles. Anterior interosseous syndrome. Compression mainly of the motor nerve, most commonly caused by tendinous origin of the deep head of the pronator tears, causing difficulty moving the index and middle fingers. Management. If a person has a working diagnosis of carpal tunnel syndrome, a CT, following initial assessment, provide advice on possible lifestyle changes, advise to avoid repetitive hand-wrist movements, and take regular breaks from tasks that precipitate symptoms. Advise on the possible need for a workplace assessment if there are work-based risk factors, and encourage referral to an occupational health department if clinically appropriate and available. Advise on driving safety, for example, after carpal tunnel surgery. Optimize management of any underlying condition, if possible. There are mild or moderate symptoms. Offer a 6 to week trial of conservative treatments in primary care, if available. Options include use of a wrist splint in a neutral position at night. These may be fitted by the local musculoskeletal service, depending on local referral pathways. A single corticosteroid injection into the carpal tunnel. This may be carried out in primary care if there is appropriate expertise and experience available. Otherwise, arrange referral to the local musculoskeletal service or orthopedic surgeon, depending on local referral pathways. Hand exercises and median nerve mobilization techniques. These may be offered by the local musculoskeletal service, depending on local referral pathways. Advise on the need for review after 6 weeks, depending on clinical judgment, if symptoms persist. Advise on the need for earlier review, if symptoms worsen or new clinical features develop. Explain that the symptoms may resolve within 6 months. This is most likely to occur in young people, less than 30 years of age, if the symptoms are unilateral and of short duration, and in women in whom fluid retention due to pregnancy is the precipitating factor. There is limited evidence that a splint worn at night is more effective than no treatment in the short term. But there is insufficient evidence regarding the effectiveness and safety of one splint design or wearing regimen over others and of splint over other non-surgical interventions for carpal tunnel syndrome. However, splints are often beneficial for many patients. Advise minimization of activities that exacerbate symptoms. There are no data to support that non-steroidal anti-inflammatory drugs are superior to placebo in the treatment of carpal tunnel syndrome. However, in absence of contraindications, a trial of NSAIDs may be appropriate and may be beneficial. Consider referring patients when the diagnosis is uncertain or where treatments have failed to work after 3 months. In addition, patients with severe symptoms, especially if there is motor weakness of the thumb or persistent sensory or motor disturbance, should also be referred. Corticosteroids. Local steroid injections are widely used for diagnostic and therapeutic purposes in the management of carpal tunnel syndrome. One study has demonstrated that the response to steroid injection was around 70% after 1 month. Those with less severe nerve compression shown on an MRI scan were more likely to respond compared to those with more severe compression. A randomized, placebo-controlled trial has shown that methylprednisolone injections for carpal tunnel syndrome have significant benefits in relieving symptoms at 10 weeks and reducing the rate of surgery 1 year after treatment. However, around 75% of patients still had surgery within 1 year. Another study has shown that both local steroid injection and surgical decompression are effective treatments in alleviating symptoms in people with carpal tunnel syndrome at 2-year follow-up. Arrange referral to an appropriate specialist depending on local referral pathways, such as a local musculoskeletal service, rheumatologist, orthopedic surgeon, hand surgeon, or neurologist. The urgency depending on clinical judgment if the diagnosis is unclear. There are persistent symptoms despite a trial of conservative treatment in primary care. There are progressive symptoms or clinical features of severe disease impacting on daily function. There are recurrent or persistent symptoms following carpal tunnel surgery. Specialist assessment and management. Complex investigations are not necessary before starting conservative treatment in clinically obvious cases. However, in cases of diagnostic doubt and before surgery, nerve conduction studies should be considered. Investigations are useful in patients whose clinical features yield a high index of suspicion for carpal tunnel syndrome, but who fail to respond to first-line treatment. Electroneurography. This is the gold standard investigation for carpal tunnel syndrome. The median nerve is stimulated proximal to the carpal ligament and compound muscle action potential is picked up over the thenar eminence. Electromyography, as is useful in some cases but is not as sensitive as ENG. Ultrasonography. This is being used increasingly as a confirmatory test. It is obviously relatively cheap, quick, and non-invasive. MRI scan. This can be used as an alternative to ultrasonography and when electrophysiological studies are ambiguous. Carpal tunnel syndrome can be classified into three groups according to the nerve T2 signal and the flattening ratio at the hook of hamate level. Group 1 high and oval, Group 2 high and flat, Group 3 low and flat. Specialist assessment and management. Nerve conduction studies, NCS. Nerve conduction studies measure the strength and speed of impulses propagated down the length of a peripheral nerve and may be useful to detect impaired median nerve conduction across the carpal tunnel, quantify the severity of disease, and provide a baseline for assessment of recovery. They may also help to exclude other conditions, such as polyneuropathy and radiculopathy. A population-based study noted that NCs have moderate sensitivity and specificity and a low positive predictive value in carpal tunnel syndrome. And people may benefit from carpal tunnel surgery with normal NCS results. Carpal tunnel surgery. An open or endoscopic surgical technique may be used for carpal tunnel decompression, which have similar outcomes in studies. The American Academy of Orthopedic Surgeons Clinical Practice Guideline found strong evidence that surgical treatment of carpal tunnel syndrome should have a greater treatment benefit at 6 and 12 months compared with splinting. Non-steroidal anti-inflammatory drugs and a single corticosteroid injection. The risks of surgery include sensitive scar, neurovascular damage, and complex regional pain syndrome. The Royal College of Surgeons of England cites recurrence rates after carpal tunnel decompression between 0.3% and 12%. Surgical treatment consists of the release of the nerve by cutting the transverse carpal ligament. This can be done either with an open approach or endoscopically. Although surgery usually produces good outcomes, it has disadvantages, which are mainly surgery-related pain, hand weakness, and complications from surgery. The open approach and endoscopic approach for carpal tunnel release are about as effective as each other in relieving symptoms and improving functional status. Return to work is faster after endoscopic release, by 8 days on average. Ultra-minimally invasive sonographically guided carpal tunnel release is a relatively new technique which preserves the superficial anatomy and diminishes the damage of a surgical approach. There are numerous rehabilitation treatments available after surgery. These include immobilization using a wrist orthosis, dressings, exercise, controlled cold therapy, ice therapy, multimodal hand rehabilitation, laser therapy, electrical modalities, desensitization, and arnica. However, there is limited and, in general, low-quality evidence for the benefit of these. Following surgery, patients have been shown to return to work to modified duty at an average of 12 days, and to full duty at an average of 19 days after surgery. Other treatments. Acupuncture has been shown to be beneficial and can improve symptoms, grip strength, and electrophysiological function. Physiotherapy may involve stretching the wrist to help increase blood flow, therefore promoting healing. Simple exercises, such as wrist bend, wrist lift, and wrist flex, to help improve the patient's strength and flexibility. Nerve glide exercises to improve the mobility of the median nerve. However, some exercises may exacerbate a patient's symptoms. There is limited and very low-quality evidence of benefit for all of a diverse collection of exercise and mobilization interventions for carpal tunnel syndrome. There is only poor quality evidence from very limited data to suggest that therapeutic ultrasound may be more effective than placebo for either short or long-term symptom improvement in people with carpal tunnel syndrome,